Hey guys, waiting for the stream to go live just to ensure. Right. So I guess we're live now and you guys can start joining. Please do remember to hit the like button for this particular video. And let's just start. Okay, great. So first of all, welcome to Let's Crack NEET PG, the YouTube channel for Unacademy, our NEET PG division, right? Where we have the top educators, quality content, and a great learning experience. My name is Chetanya Mittal. I'm currently pursuing my MBBS from AIMS New Delhi. I hope you've already downloaded the Unacademy Learning app. All you have to go do is go to the Play Store and download the Unacademy Learning app. Log in with your email address, phone number, then choose NEET PG as your goal. Right, even if your goal is actually INI-CET or some other institute, and NEET PG is your goal, and you will need an invite code. You can use my invite code Chetanya10 to unlock the free plan, get access to everything that is free on Unacademy. I'll just shortly tell you about all that. So we have the top educators teaching live with us on Unacademy, and we're all making plus courses for you. Of course, these are plus paid courses, and these will require you to have a subscription to access them, right? But at the same time, to give you an demonstration or how the live experience actually feels like, we're also making free of cost special classes. And even if you don't take a subscription, you can take full advantage of these free of cost special classes. All you need is my invite code to access them, right? So Unacademy as a subscription has now become an all-in-one feature where we have batch courses which are meant to give you the live classroom experience. And if you want to give tests and attempt MCQs, we have special tests and weekly tests which are on real mock test pattern with real timings. And we have an ask a doubt feature where you can ask all your doubts to the experts and get your doubts cleared. So that solves all your needs and makes Unacademy a all-in-one solution, right? So you can see what are the batches. We have batches for NEET PG, we have batches for the next examination, we have batches for INI-CET, right? And we have batches for FMGE going on. This class is specially for the first prof students, second prof students, and those who are preparing for INI-CET, because this class will have what are called as EMQs, right? So these are the free tests that you can attempt on the application to practice. There are daily mock tests that are being conducted, which are absolutely free of cost. And this is the way Unacademy provides you flexibility with your schedule, because you can watch the lectures as many times you want with your language. And you can just go ahead and download the application, take advantage of the chat feature as much as you want. And there are two kinds of subscriptions. There's an Unacademy Plus subscription and there's an Unacademy Iconic subscription, right? So the Unacademy Plus subscription, you have the entire live experience I just told you about. Okay, the live classes, live tests, live quizzes, the batch courses, and a structured schedule along with doubt clearing sessions, right? Whereas if you talk about Prep Ladder, that is included in the Iconic subscription. So as you know that Unacademy, India's largest online learning platform, has acquired Prep Ladder, which was a leading player in the medical coaching industry, right? So here you can see that Prep Ladder, which has some of the top faculty teaching, so you get access to their video lectures, their question banks, right, and the handwritten notes. This is very, very important because these are very good when you have to revise things very quickly, right? The most important points very quickly. They can be very easily revised from notes. So the 1 year subscription costs 55,000 and the 2 year subscription, it costs 77,000. You get access to all 19 subjects. And if you use my referral code Chetanya10, you are eligible for an additional 10% discount. You can use this code for any kind of subscription, NEET UG, NEET PG, JE, any kind of subscription, right? And you will get this discount. So you can see the pricing for after the discount for Iconic. And for Unacademy Plus, this subscription is different. The 1 year subscription here, it will cost you merely 25,000, and the 2 year subscription will cost you 36,000. This is very well priced as compared to our other peers where the prices will go above 40,000, right? So you can see this is how you can enter the referral code and this is how you can apply the credits. So now coming to what EMQ questions are. Yesterday, if you haven't seen yesterday's session, you can go ahead and watch part 1 of the session. This is EMQ part 2 because yesterday we had a slightly shaky connection. So today I hope that issue is resolved and you guys are able to see the video properly. You guys are able to listen to what I am saying properly, right? So Yeah, I hope that is resolved. And for each disorder, so what happens basically in such a case is that you have a question that is the focus. You have a theme, right? You have a theme. Then you have a focus. Then you have a lead in question. That question will lead you to the main parts of the question. Then you have the options. Then you have the answer options, right? These are all the options. And after that, you will have multiple clinical case scenarios that you need to address, right? So am I clear with how this would proceed? Okay, so there are a lot of learning points in each question. So we've done this first question regarding disorders of hemostasis. We've done the first question regarding disorders of hemostasis. After that, we have done this second question that is about acid-base balance disorders, right? Then we discussed this third question about fluid disturbances. And then this was our fourth question about a blood transfusion, right? So now moving on to the fifth question for today. So, what is the theme here? The theme here is anemia. The theme here is anemia, and the focus is types of anemia, right? And the various disturbances in them. So, these are the options that are given to you: iron deficiency. I think it's fine now. Hello, guys. I think it's fine now. Hello. Check. Sorry, guys. Sorry for the inconvenience. I'll just give me 1 minute to figure out the technical issues. Right. So sorry, really, really sorry for the inconvenience, guys. Let's begin with a fresh start. And welcome to Let's Crack NEET PG, the YouTube channel for Unacademy, our NEET PG division. And you guys are watching. Right. So where we are showing you the top educators, quality content, and a great learning experience. So working our best to give you the top content possible. My name is Chetanya Mittal. I am currently pursuing my MBBS from AIMS, New Delhi. And I hope you all already downloaded the Unacademy Learning app. So if you haven't downloaded it, just go ahead to the Play Store and download it. All you need is to log in with your email, register, and you will need my invite code. So just use my invite code Chetanya10 and you will get access to all the free content that is there on Unacademy, right? So we have the top educators teaching live for us on Unacademy, and these educators we're all making plus courses for you, and these plus courses are of course paid, and you need a subscription to access these. At the same time, to give you a experience of how Unacademy live feels like, we have free of cost special classes which are there to give you an experience of Unacademy plus. So there are three features that are there in the Unacademy plus subscription, and you will see that they make Unacademy a one-stop solution. We have the live classroom experience with batch courses, right, where we will be giving you all 19 subjects complete coverage, and testing is through special tests and weekly tests. And we've also introduced an ask a doubt feature where you will have all your doubt clearing sessions, right? So all of this is included in Unacademy, and you can see what are the upcoming or what are the latest batches. So these batches are they've all started on 1st March. So you can see what are the batches that are ongoing. So we have batches for NEET PG, INI, CET, FMGE, and next, right? And you can also attempt these mock tests absolutely free of cost in case you guys wish to attempt these. And Unacademy is actually the easiest way to learn NEET PG online because it gives you flexibility in terms of schedule, in terms of language, and it has a very robust chat feature, so you can take maximum advantage of that, right? And there are two kinds of subscriptions, Unacademy Plus and Unacademy Iconic. So in Unacademy Plus, you get access to live classes, live tests and quizzes, batch courses, and structured schedule. The entire classroom experience is being provided to you by Unacademy. Unacademy has also recently acquired Prep Ladder. So you will get access to the video lectures, the question bank, and the handwritten notes, along with the rapid revision course in the Iconic subscription, right? So there are two kinds of subscriptions, Unacademy Plus and Unacademy Iconic. So if you don't have Prep Ladder, I would say you go for Iconic, right? The 1 year subscription, it costs you 55,000. You can apply my referral code Chetanya10. You will get a 10% discount straight away on this, and the final net cost to you would be 49,500, which can be reduced further by applying credits, right? And the 2 year cost is 77,000, right? And if you use my referral code Chetanya10, this can be reduced to 69,300. So it's almost a 7,000 rupees discount. And besides that, the Unacademy Plus subscription, if you buy without Prep Ladder, for 1 year it costs 25,000, and for 2 year it costs 36,000, right? So go ahead, purchase these subscriptions, and start your learning today. Use my referral code and apply the credits, right? So yesterday I had session 1 of the EMQ type, right? But yesterday's session there were some network issues. I was also facing those issues today. So we'll try to recap what we did very quickly today, so that you guys, those who were not able to watch yesterday's video due to technical issues, they can also have a look at it. So what are EMQs? EMQs are called as extended matching questions, right? Or extended matching items, right? Extended matching items, right? So there is a theme. There is a theme. The theme, for example, in this question is hemostasis. There is a theme, that is hemostasis. Then there is something called as a focus. Okay, so regarding hemostasis, what is the focus? The disorders of hemostasis, right? The disorders of hemostasis. Then there is a question that is called as a lead-in question. Okay, lead-in question means that this question will lead you to the main questions. So it is giving you that there are disorders of hemostasis that are given in some cases, and you have to choose from these findings. So these are called as the answer options. These are called as the answer options. That is the options from which you have to choose your answers. After that, there are 5 clinical case scenarios. Okay, so let's call this case 1, or you also could call them STEM 1. Okay, STEM. Okay, so STEM 1, this is your first clinical case scenario, right? So for example, in disorders of hemostasis, it is given that a 15-year-old child has pinhead areas of purpura. So what is the cause of purpura in a 15-year-old child? You have to try and guess that given the options that are provided to you. So in a 15-year-old child, it's mostly because of thrombocytopenia, right? So the answer for this case will be a platelet deficiency. Normal platelet count is 150 to 450 into 10 to the power 9 per liter, and in this case the platelets would be very low, approximately 20 into 10 to the power 9 per liter, that is thrombocytopenia, right? So I'm just recapping what we did yesterday in a very quick way. I'm not giving you guys time to answer. If you guys like the video, do remember to hit the like button, because these are all clinical case scenarios. You'll all find them very interesting. And for the first time, I am the educator who's bringing EMQs for INI-CET to you guys, because you will see that there are no other videos on YouTube which are specifically for EMQs for your NEET PG or INI-CET preparation. And I personally find them better than MCQs from a learning point of view. Why? Because see, they are doing two things. What is the most difficult question in INI-CET? Most difficult question in INI-CET is an EMQ question, because it takes so much time and you are not used to solving these kinds of questions. The second thing is that the next exam that will start from 2022, it is going to be clinical in nature, so that it is likely that such questions will come, right? And the best part is that since these are clinical scenarios, they will provide you conceptual clarity with whatever you do. Okay, and at the end we will discuss the entire concept behind a complete question. So it's a very holistic approach to learning through questions, right? The second question here, the person is receiving anticoagulant therapy. Warfarin is being given, right? So warfarin, it causes a deficiency of warfarin. Basically is an antagonist of vitamin K. So since it is an antagonist of vitamin K is used to synthesize factors 2, 7, 9, 10, right? So factor 2 is prothrombin. So this patient will have a prothrombin deficiency. Therefore, his INR, that is the international normalized ratio, is raised. For a patient on warfarin, the INR ratio should be between 2 to 3, right? So that is the finding in this case. Third case, 90-year-old woman has blotchy purple area. So these are called as port wine stains. These are called as port wine stains. They are seen in elder women. So this 90-year-old woman is significant. 90-year-old woman, her vessels will be weak. So she has a capillary anomaly. She has a capillary abnormality, right? So that is the answer in this case. Okay, so you can have a look at the options later, the answers that I'm telling you. 70-year-old man, he has an aneurysm, right? So remember, always an aneurysm or an aortic dissection is generally, you will see on questions, it is associated with a massive blood transfusion. A massive blood transfusion means that more than 10 units of blood are given, more than one blood volume is given to the patient. So because of this, this person will develop disseminated intravascular coagulation, and the treatment for which is heparin, because you will want less coagulation to occur in this state, even though the bleeding is more. Okay, I've explained this in detail yesterday. Then last scenario, 10-year-old child with no known medical problems has been admitted to hospital for persistent bleeding after tooth extraction, right? Hemostasis has been achieved initially after extraction, but subsequently prolonged oozing from the tooth socket. So is this a bleeding disorder or a coagulation disorder? I'd asked you this yesterday, right? Is this a bleeding disorder or a coagulation disorder, right? So you can see initially when there was hemostasis was achieved initially. So that means there is no bleeding, but there is a problem with coagulation. So this is a coagulation disorder, and this is how factor 8 deficiency or hemophilia will present to you. There's a young child, so it's probably undiagnosed so far. And the fact that hemostasis was achieved initially, but then later there was prolonged oozing, that shows that platelet plug was formed, but then there were not enough clotting factors there, right? So this is the clotting factor, this is the clotting pathway. I've also explained this to you guys yesterday. What is the clotting factor pathway? How does it work, right? So this was about question number 1. Do you guys understand EMQ number 1? Are you guys clear about EMQ number 1? Right? Any doubts? And guys, those who are watching, please hit the like button so that I know that you guys are understanding, you guys are finding these scenarios interesting. Come on, bring the like button on. And you guys definitely drop in a hello or something. And please write that you've understood how EMQs work and you are finding these questions interesting or at least helpful for your preparation. Anyone? Hello. I can see 5-7 people are watching. So you guys, if you're at a previous path, that's okay. But just whenever you come to this part, do drop a message, right? So let's come to question number 2. So I think we're done up till question number 1 yesterday. I actually had done 4 questions, but they haven't come properly. So I'm quickly going to summarize this question also. And so you can see in this case, let's have a look at these options first. Okay, so they're all cases of disturbed acid-base balance. So that is your theme and focus. That is your theme and focus. So if you have a look at these scenarios, this option number 2 is giving you the normal values. The normal pH is between 7.35 to 7.45. So the normal pH here is given to you 7.4. Normal concentration of oxygen is around 14 in kilopascals, right? Normal concentration of carbon dioxide in kilopascals is around 5, and the bicarbonate is around 25. 24 to 28 is the normal range, right? So you can see that which are the cases where you have acidosis. So acidosis we will write in orange. Okay, we'll write acidosis in purple. So this is acidosis, and this is acidosis. This is also acidosis, right? Then let's identify alkalosis. This is alkalosis and this is alkalosis, right? So now alkalosis, which is because of low levels of carbon dioxide. Alkalosis, which is because of low levels of, why will you have metabolic alkalosis? Because of high amounts of bicarbonate, right? You will have metabolic alkalosis because of high amounts of bicarbonate. So this is metabolic alkalosis, right? And this is because of low amounts of carbon dioxide. So this is because of respiratory alkalosis, right? This is called as respiratory alkalosis. Now in this case there is a high amount of CO2, and in compensation the bicarbonate has also risen. So this is basically respiratory acidosis on hyperventilation, right? This is respiratory acidosis with hyperventilation, right? um, Here the cause for acidosis, here you can again see the cause for acidosis is again because of CO2. So this is also respiratory acidosis. And this one here, the bicarbonate levels are low, so this is metabolic acidosis. This is metabolic acidosis. The main difference between these two acidoses is the level of oxygen. In this case you have hyperventilation, in this case you do not, right? So this is the entire breakup of this uh, flowchart, right? So 60-year-old woman, bronchitis. So if she has chronic bronchitis, which means that her oxygen levels have to be low, and she has respiratory problems, so it's likely a case of respiratory acidosis, right? Respiratory failure, so reduced oxygen levels, and the patient should have acidosis with high carbon dioxide levels. So that is likely corresponding with option 3, right? That is corresponding with option 3. Here look at this 50-year-old man is long-standing chronic bronchitis, but the difference here is that he is receiving oxygen therapy. So since the patient is receiving oxygen therapy, look at option number 5. The oxygen levels are high, but the patient still has respiratory acidosis. So this corresponds to option number 5. B corresponds to option number 5. C, a 50-year-old woman with long-standing renal disease. Patient has renal disease with marked drowsiness and is noticed to be hyperventilating. So hyperventilating is the respiratory response. It is the respiratory response to throw away carbon dioxide, and it is the respiratory response to metabolic acidosis. So this is likely to be option 1. This is likely to be option 1. Then if you look at question number D, 25-year-old man, he's taking part in a mountain climbing expedition in the Himalayas, and the medical officer of the team is carrying out physiological measurements. The subject has been through the usual protocol for acclimatization to high altitude. So in this particular case, in case number D, the high altitudes, they will cause hyperventilation because there is hypoxia, right? And in that case, you will have respiratory alkalosis. You will have respiratory alkalosis, and in compensation, the bicarbonate levels will decrease. Last case, 30-year-old man has been suffering from abdominal pain and malaise, long-standing upper abdominal pain, and he's been taking a large amount of sodium bicarbonate. So this is a very special case where the patient himself is treating his peptic ulcer disease with sodium bicarbonate. But when this sodium bicarbonate is absorbed, it leads to metabolic alkalosis because it increases his bicarbonate levels. So this you will correspond with option number 5, where there is metabolic alkalosis. There is metabolic alkalosis, right? So I think this much is clear. Question number 2 is clear, and this is what is called as the Davenport diagram. So one question that can be asked to you is, what are the Davenport diagram is a graph between. So it is the graph between serum bicarbonate concentration and arterial blood pH. All right, and the lines that you draw here, these are called as isobars. These are carbon dioxide isobars, because here the partial, along these lines, partial pressure of carbon dioxide is same. So as you the normal pH range is 7.35 to 7.45. Anything that is towards the left of this will be acidosis, and anything towards the right, anything towards the left of this is acidosis. Wait, let me just make these completely. Anything towards the left of this will be acidosis, and anything towards the right will be alkalosis, right? And if the carbon dioxide is more, that means that it is a respiratory acidosis. If the bicarbonate is less, that means it is a metabolic acidosis. Similarly, if the carbon dioxide is more, it is a metabolic alkalosis, and if the bicarbonate was more, it is a metabolic alkalosis, and if the carbon dioxide is less, it is a acute respiratory alkalosis. And respiratory acidosis and alkalosis, they can be compensated by renal changes. So there is a compensation that is shown for when the acute condition actually becomes chronic. Okay, understood. Are you guys clear with what I have told you so far? EMQ number 2 is done. You guys think EMQs are useful? Did you guys understand anything from these 5 clinical case scenarios? Did I go too fast through these 5 clinical case scenarios? Quickly. Sandeep Rama was good. Okay. Okay. So I know you guys might be thinking that I'm not letting you guys solve these, right? But believe me, I'll give you from question number 5. You guys are going to solve this, right? Because these I discussed yesterday, but they're not there in the recorded lecture of yesterday. So I know that people could not watch because there was video lag issues, and that is really really irritating for anyone who is seriously watching a lecture. Right? So that's why I'm quickly revising these ones with you. And then when you guys want to attempt them, you guys can also attempt them on your own. Okay. So let's move on to question number 3. For each case of fluid disturbance, select the most appropriate option from the following list, right? So have a look at this. There is a 20-year-old mentally disturbed patient, and he has refused all food and drink. So if the person is not having any food, anything to drink, that suggests that the patient is having decreased total body water. So that is going to be the correct case scenario in this case, and that is why his plasma osmolality is also raised and his urine output is severely decreased. Normal urine output minimum must be 500 ml. So if this person is not given something to eat or drink, his urea levels will be dangerously high, right? So that is very very important here. Okay. Next, let's go to option C. A 50-year-old woman is suffering from weakness and mild confusion. So, weakness and mild confusion, these are neurological symptoms. And even before I've read the rest of the question, I know that these are because of hyponatremia. So, whenever you talk about electrolyte disturbances, hyponatremia typically presents with weakness and mild confusion. So, and you can see plasma sodium level is 125. Normal plasma sodium levels is going to be 135 to 155. Some books also say 145 or 150, right? So this is variable, but this is the one that you will see in lab reports, 135 to 155. So anything below 135, that is biochemical hyponatremia, and anything below 130, that will present as actual, that will have actual manifestations, actual symptoms. So 125 is actually very low, and if it goes below 120, the patient can also have coma and everything, right? So, and in this case, the patient has raised levels of vasopressin. So vasopressin levels are increased. That shows to me that in this particular case, the total body water will get increased, because vasopressin is responsible for removing the free water of the body, right? Then in case scenario D, the woman was admitted, 80-year-old woman. She had vomiting, several transfusions of blood. So transfusion of several pints of blood, the patient becomes breathless, which means that since she is an old woman, you have overloaded her heart with several amounts of blood, right? Because see, when the patient's heart becomes old, it cannot take a large amount of blood volume. So because of that, you have given lots of blood to a patient. Because she had a lot of vomiting, you thought that she is having fluid loss, but you have given her increased blood volume. You have given her increased blood volume more than she should have, right? So in case of increased blood volume, what will happen? Her heart will not be able to take this amount of blood volume, and because of that, she has increased jugular venous pulse. And why is she breathless? Because of pulmonary edema. Because her heart is not able to pump the blood is accumulating in the lungs. So there is pulmonary edema, right? Understood. So if you guys are liking this way of presentation, this way of understanding concepts, please do remember to hit the like button, make this video as famous with your friends as possible, so that more such content can come to you. You guys can benefit from EMQs. Okay? Because trust me, nobody right now is doing EMQs in this way. Nobody right now is doing full scale EMQ practice. Okay. and EMQ is the way to learn. MCQs, you guys will learn one concept. When you do five clinical case scenarios related to one disorder and then you understand about that disorder or that concept, it's really going to blow your mind away. And it's much more beneficial to do EMQ with an educator, because MCQs you can also do on your own, but EMQs require you to rule out other options. They require you to rule out other concepts. They require you to pick up the hints in the question, and that is best done when someone is solving with you, right? So now you have a 40-year-old man admitted with full thickness burns, right? So with related to whenever you see burns, I want you guys to know one thing related to burns. There is something called as the Parkland formula. Do you guys know what is the Parkland formula? Very, very important when talking about a burns patient and body fluids, right? So what happens in a burns patient? The skin is eroded, right? And because the skin is eroded, there is a lot of evaporation. There's a lot of fluid loss. Because of that fluid loss, in that case, in that patient, there's a decreased plasma volume. Why? Because from the capillaries there is plasma loss, right? The rest of the things are fine, but there's a lot of plasma loss. And because the plasma is lost, that raises the hematocrit. So you can see in this patient that the hematocrit is 54, and because there is less plasma, the BP has also fallen. So there is a chance that the patient will go into shock. So that is why you have to give the patient Ringer's lactate, or you have to give the patient normal saline, depending on what are the other parameters. So what is the Parkland formula? First tell me, what is the Parkland formula, right? So Parkland formula gives you the volume of Ringer's lactate solution. So the first condition before applying Parkland formula is that it is only applicable in second and third degree burn, right? So what is the first degree burn? What is second degree burn? What is third degree burn? What is first degree burn, what is second degree burn, and what is the third degree burn? So first degree burn is when it only affects the outer layer of the skin. First degree burns, they will only affect the outer layer of the skin. Second degree burns, you will have blisters because the outer and the middle layer of the skins are going to be affected. The third degree burn, they will damage all the layers of the skin, right? So in that case, even the nerves may be damaged. So in that case, the patient might not even feel pain because the nerves have been damaged. But this case of Parkland formula is applicable only in second and third degree burn, right? So it tells you that see, the total amount of Ringer's lactate that you have to give is 4 ml multiplied by total burn surface area, right? Total burn surface area, right? And how do you calculate burn surface area? There is something called as the rule of rule of nines. Okay, the patient's palm, it approximates 1% of total body surface area. What is the rule of nines? The face is 9% surface area, 18% is occupied by the front, 18% by the back, 9% by left arm, 9% by right arm, 18% by left leg, 18% by right leg, and 1% by the genital region. Hello, hello, hello. हाँ जी, हाँ बताओ, क्या हो गया? यार अभी तो लगेगा टाइम। रात को कितने बजे? 8 बजे है ना? चल ठीक है, उसके बाद मिलते हैं। Okay. So look here, because the patient's body weight will also be multiplied here, right? So this is the total amount of Ringer's lactate that has to be given. Now, let's say this comes out to be 1000 ml. Let's say this comes out to be 1000 ml. You will divide this into two halves, right? So 500 ml is to be given in 8 hours. 500 ml is to be given in 8 hours. And the rest 500 ml, it will be given in 16 hours, right? So you divide it into the first 8 hours and the 16 hours. Half you will give in the first 8 hours, and then half you will give slowly over the next 16 hours, right? So do you understand Parkland formula, rule of nine? Okay, so this is the case in this particular case scenario. Then this is the fluid distribution that is for a patient. Okay, fluid distribution, composition of total body water. You can see 40% is ICF, uh, two-third is ICF of your total body weight, and 20% is ECF. So there's a ratio of 2:1, right? Then out of this, three-fourth of ECF is interstitial fluid, and one-fourth is intravascular fluid, right? Besides those, there are some transcellular fluids like synovial fluid, pericardial fluid, pulmonary fluid, and intraocular fluid like aqueous humor and vitreous humor. Okay, so this is about more or less about the third question. Fourth question is regarding blood transfusions. Fourth question is regarding blood transfusions. And again, you have to choose the most appropriate option from the given list of options, right? So, what are the options that have been given to you? Just have a look. Let's go to the first question. Patient has been given 3 units of blood, right? Just after the operation, the patient is at risk of inadequate tissue oxygenation despite satisfactory blood parameters. What is the reason for that? The reason for that is that whenever you give blood, it is usually, it might be fresh blood, but a lot of time when it comes from the blood bank, etc., it is going to be stored blood. And the problem with stored blood is that stored blood, the RBCs, they have very, very low levels of 2,3 BPG. And as you all know that 2,3 BPG, it causes right shift of hemoglobin and it is responsible for increased oxygen delivery. So if you give a patient this blood, he will not have oxygen delivery that is adequate. So because of that, the patient will take approximately 24 hours to regenerate normal 2,3 BPG. And during these 24 hours, there is a chance that even though hemoglobin is normal, blood oxygen is normal, BP is normal, tissue oxygenation is abnormal because of left shift of the curve because of decreased levels of 2,3 BPG in stored blood, right? Patient is given 2 units of blood on the day before a planned operation. So very important things, the patient gets mild fever and slight jaundice. So mild, slight, it shows you that there is a minor incompatibility. There is a minor incompatibility, right? Third case, patient is admitted with vomiting, shows circulatory failure, is given 1 unit of blood quite rapidly. Quite rapidly. It is discovered that there is a confusion between two patients. So, samajh aa gaya, the group B has been given group A. So, which incompatibility is there? Major incompatibility. There will be a major reaction and it can also be fatal for the patient. You can also call it ABO incompatibility. You can go for whatever answer you want to go for. Option D, during emergency surgery of a dissected aortic aneurysm. When I told you, whenever you see aortic aneurysm, think of massive blood transfusion. Massive blood transfusion means more than 10 units of blood or more than 5 liters or more than normal volume of blood. 20 units of blood have been given. The patient is at a risk of hypothermia. Why? Because blood, as you all know, it is stored at 2 to 6 degrees Celsius, right? So if it is not adequately warmed, there is a chance that because the patient is given such large amount of blood, the patient may develop hypothermia. And because this blood has a lot of coagulation factors, there may be coagulation problems and there can also be tissue hypoxia. Last case, patient is having a failure of bone marrow function. There is aplastic anemia and the patient is admitted for transfusion as the hemoglobin is fallen very low. Blood bank reports some difficulty in finding suitable red cells. Why? Because there are some minor blood groups like M, Kelly. There is something called as Duffy also, MN blood group, Kelly blood group, Duffy blood group, all of these. So now the reason is multiple repeated transfusions because these are otherwise minor antigens. You don't have to worry about them. But in patients who undergo multiple repeated transfusions, in those cases, in those patients, these blood groups, antibodies will also slowly develop against these blood groups. So in those cases, it is very difficult to find a donor for these patients, right? So that is about question number 4. Now we are moving to question number 5. Okay. So first, you guys will tell me what is the theme and the focus, right? Okay, I'll tell you. The theme and the focus is anemia, right? So you will be given 5 cases of anemia now. You will be given 5 cases of anemia now, and you have to select the most appropriate option from the following list. You have to select the most appropriate option from the following list. So it's your turn to choose it. Let's go. Which one do you think it is going to be? Right? So these are the options: iron deficiency anemia, pernicious anemia, microcytic, macrocytic, normocytic, bone marrow, compensatory rise in cardiac output, decreased blood viscosity, hemolytic anemia, and increased bone marrow activity. So now you are given the first case scenario. A, you're given the microscopic picture of a patient with anemia, right? Allow me to just go and get some water for myself. Just give me 1 minute. I'll be back in 1 minute, right? Meanwhile, I want answers from you guys. So these are the options, and this is the question, right? Right. So guys, what is your answer? The microscopes, the RBCs, they appear normal under the microscopes, and the MCV is given to you. So what is the normal range for MCV? RBCs appear normal, and this MCV is also in the normal range, right? So it's already been told to you that the patient has anemia. The patient has anemia, right? So 90 cubic microns is the mean red cell volume, and it appears normal under the microscope. So this patient, and I've already told you it's an anemia patient. So this is obviously normocytic anemia. This is normocytic anemia, right? So, what are the causes of normocytic anemia? Okay, so we'll discuss the causes of each type of anemia at the end. But you have to know this is normocytic anemia. So, if everything is normal, what is the actual defect, right? What is the actual defect? What blood parameter will have some problem in it? Which blood parameter will actually be abnormal, right? So, I've told you that the RBCs they look normal. The mean red cell volume is normal. So, which parameter will actually be affected? Which parameter will actually be affected? Of course, hemoglobin. Hemoglobin is going to be low. Hemoglobin is going to be low. What will happen to the MCH or the MCHC? What happens to MCH and MCHC? Will they be also decreased? Okay, you guys will tell me regarding question 1, what will be the effect of all of this on these parameters, right? Am I clear with this question? Sandeep, Kadambari, I want you guys to answer as well. I want you guys to also give your answers. Chalo. From second question, let's try to answer. Option question number B. Patient long standing indigestion. Chalo. Try to read the question on your own and try to answer, and then we'll discuss it. Right. So I'll read the question for you guys, and then you guys try to answer it. I'll give you the hints also. Okay. A patient has long standing indigestion. Okay, patient has long standing indigestion, has noticed an increasing lack of energy and tiredness when walking uphill. So these are classical symptoms of anemia. Patient has increasing lack of energy, tiredness when walking uphill. On questioning, he has noticed that the bowel movements are unusually dark from time to time. Right, so his bowel movements are unusually dark. Due to the indigestion, the patient takes a bland diet without much meat or vegetables. What do you think is the cause for his anemia? The stool that is unusually dark. What do you think is this stool that is unusually dark? What is this called as? Have you heard of the term called as melena? Do you know what is melena? Blood in the stools, right? So unusually dark stools, the blackish colored stools, they are degraded hemoglobin. So this is melena. Absolutely correct. It will be microcytic, but your answer should be your answer out of these options. You should choose the best answer. Okay. So Garvit, Sandeep, try to choose an answer that is the best answer. Garvit, it's not pernicious anemia. Okay, it's a microcytic form of anemia, and it's specifically iron deficiency anemia. Now, how do you identify that it is iron deficiency anemia? Right. So it is first given. So I think I know why you're thinking pernicious anemia, because the patient is not taking vegetables or meat. So you're thinking that the patient is not having enough amount of B12. Right. So that's what you're going for. But if you look at the patient has had this melena is very suggestive of microcytic anemia. So this melena basically means that there is blood in the stool, which indicates there is some GI bleed. There is some bleeding in the GI, right? And since there is bleeding, there will obviously be iron deficiency. You will need more iron. And since the patient has indigestion, the patient is not having, so the patient is not having enough amount of vegetables, is not getting enough amount of iron, right? Although for iron, they should have written something more specific. And a confirmatory finding would be actually presence of red blood cells in stool. But this melena is the hint that it should be iron deficiency anemia, right? That is going to be the correct answer as given by Sandeep. So Sandeep, instead of microcytic, you should say here iron deficiency anemia, right? Because the patient is having a diet which is likely to be low in iron. Okay, likely to be a microcytic anemia, but to say that it is microcytic anemia, it should be given somewhere in the case that there are small pale red cells, right? That those words are required. The answer can also be microcytic anemia otherwise, because iron deficiency anemia is a specific type of microcytic anemia, right? Let's go with option question number C. Let's go with option number C. Question number C. So you are seeing that the patient's blood hemoglobin is 60. Do you think the hemoglobin is normal, or is it increased, or is it decreased? Blood hemoglobin is given 60. So if you guys are actually liking the video, please do remember to hit the thumbs up button, right? That's there for you guys, so that you can tell other people that you actually like the video. Do share the video with other people, because EMQs is a relatively new concept. Very few educators teaching EMQs. Patient. So let's read the case again. Garvit, Sandeep, you guys can answer. Patient has a blood hemoglobin of 60 grams per liter, right? So you'll convert it to deciliter. So this is 6 grams per deciliter. So the patient definitely has anemia. The patient definitely has anemia, right? Any doubts about the fact that the patient has anemia? The patient has anemia, right? Complaints of recent palpitations and abnormal awareness of the heart. Yes, okay. When at rest, the pulse is 110, right? So he has tachycardia, and the blood pressure is also on the higher side. The blood pressure is 140 over 60, right? So, what is your diagnosis? What is your diagnosis? There is a very specific term for this kind of a circulation. This kind of a circulation, there's a very specific term that is used, and okay. So you think this is iron deficiency? No. Just have a look at the options here. Just have a look at the options here. I'll just correct this. So, what do you think is there? This is the correct option here. Compensatory rise in cardiac output. Because you can see that what happens in anemia. In anemia, the oxygen is not less, right? The oxygen that is going to the tissues is less. So in response, your heart, it says that hemoglobin to पहुंचा नहीं पा रहा. So that means the heart has to pump faster. The heart has to pump with more pressure. So it leads to an increased cardiac output. There's an increased workload on the heart, right? So that is one characteristic compensation for anemia. Okay, and this circulation is called as hyperdynamic circulation. This circulation is called as hyperdynamic circulation, right? Hyperdynamic circulation. right? So let's move ahead to the next question. A woman of 75 has noticed unusual lack of energy recently and feels. I hope you guys are clear. I was waiting for your doubts. So, next question. Woman of 75, so this is the age of the woman, has noticed unusual lack of energy recently and feels she is paler than usual, right? So paler indicates anemia. Her hemoglobin level is 110 grams per liter. So it's 11 grams per deciliter. That's slightly low, but since she's a woman, I guess we can consider that it is not too low. And the red cell count is depressed beyond that expected with the fall in hemoglobin. ठीक है, तो इसका मतलब red cell count is much more lesser than what is to be expected with the fall in hemoglobin. This line is very important. This line is very important. That hemoglobin level, it is 11. Hemoglobin level, it is 11. So RBC should only be slightly less, but the case is telling you that the red cell count, it is much more lower than it should be, right? And circulating level of vitamin B12 is very low. Now there is your hint. There goes the entire hint of the question. Okay, so these two lines, they will confirm your diagnosis. This line will tell you what the suggestive diagnosis is, and this line will confirm your diagnosis. Okay, so tell me, what is the diagnosis? Sandeep, Garvit, according to you guys, what is the diagnosis here? Not too difficult, come on. Okay, so very simple. Let me just finish this one for you also. So see, the woman, he has a very low level of vitamin B12, so that suggests that it is pernicious anemia. That suggests that this is pernicious anemia, right? So why is the hemoglobin almost normal? The reason for that is the RBCs, they are very large in size, right? So because the RBCs, they are large in size, every RBC can accumulate more hemoglobin. So they are macrocytic. They are macrocytic. So therefore, even though the hemoglobin is less, the RBCs, they are much lesser because one RBC is now accumulating much more amount of hemoglobin. But that still means that the RBC is less. The patient has anemia. Hemoglobin is also on the lower side. So the woman, she has macrocytic anemia. Okay, that's the final answer for this one. Last question, question E. Last questions related to anemias. Chalo, read this question. A patient with moderate anemia is found to have a brute, right? So it's described as an abnormal murmur, right? When a stethoscope is used to listen over each of the carotid arteries in the neck. The doctor is inclined to attribute the murmur to a physical effect of anemia on the blood rather than to an abnormality of the carotid arteries. So, what has been asked to you that what is the reason for this murmur? What is the abnormality that is there because of this? Okay, so the reason for this abnormal murmur is that what is this effect of anemia on the blood? And that is there's only one option that you will find that is relevant here, and therefore this one is a slightly easy match. The option is decreased blood viscosity because there's less amount of RBCs, so the blood viscosity is decreased, and because of that you have an abnormality in blood, right? So that brings us to the end of this question. That brings us to the end of question number 5 related to anemias. Now I have a slide for you where we'll try to list out what are the various causes of various kinds of anemias. Very, very, very high yield. Okay, so let's first do it through this slide. So anemias, you can have three kinds of things. You can have a low mean cell volume, or that is less than 80. So this is called as a microcytic anemia, right? And the main cause for this, or the most common cause for anemia itself, is iron deficiency anemia, right? Then normal would be, this would be normocytic anemia, that is the mean cell volume remains between 80 to 99. And the last is macrocytic or high mean cell volume anemia, where mean corpuscular volume, where the MCV is greater than 100, right? So for low or microcytic, it is mostly going to be iron deficiency anemia. You can also have sideroblastic anemia, thalassemia, and anemia of chronic illness, right? Anemia of chronic illness. But anemia of chronic illness can also be normocytic, and other cases of normocytic MCV is G6PD deficiency, hereditary spherocytosis, and TNH, that is paroxysmal nocturnal hemoglobinuria, right? So we'll probably talk about this anemia in detail sometime later. It's very, very interesting. But for now, these are the case causes for normocytic, and for macrocytic, it is mostly B12 or folate deficiency, right? So have a look at this table. Macrocytic normochromic anemia, right? Macrocytic normochromic anemia. So in this case, vitamin B12 deficiency, you will see an increased MCV and a normal MCHC, right? MCV is more than 100 femtoliter and MCHC is around 34. Okay, that's the normal. If you look at microcytic hypochromic anemias, the main cause would be iron deficiency anemia, thalassemia, and anemia of some cases, very rare cases, right? So in general, if it is asked, it is a normochromic one. So I'll even cross it from here. You don't need to know this. Whenever it is asked, choose normocytic over microcytic. And in this case, you will have a low MCHC, low MCV will be less than 80 femtoliter, and MCHC will also be less than 30. Normocytic normochromic anemia, it's the MCV is normal, right? It lies in the range of 80 to 99. MCHC is also 34, normal MCV, right? And the main reason is anemia due to chronic illness, anemia of acute hemorrhage, aplastic anemias, hemolytic anemias. In this case, there is no effect on the size or the hemoglobin concentration of an RBC, right? Are we guys clear? If somebody asks you that Which of the following is an example of a normocytic normochromic anemia? You'll be able to choose which of the following anemia is macrocytic normochromic. Will you be able to choose the answer? Is this difficult? Types of anemia, the examples, very, very important. If you guys are liking the video, please do remember to hit the like button. Right, so question number 6. I hope you guys have read the options. For each lipid related topic A to E, you have to select the most appropriate option, right? So you have coronary artery disease, risk factor, source of energy, some options, right? Just have a look at these options. So coronary artery disease risk factor. So you might be asked which lipid is a coronary artery disease risk factor, or let's see the questions, and based on that you'll have to decide this. Source of energy, where lipid is acting as a source of energy. Cell membrane solubility, cell membrane structure, metabolic energy per unit mass derived from cholesterol, body lipid stored, lipase, carbohydrate hormones, protein hormones, right? So you have certain options. So let's see option A. When explorers when explorers were crossing Antarctica, trailing all their food in a hand sleigh, there was an advantage in taking a high proportion of fat rather than carbohydrate. So, what is the reason for that? What is the reason for that? Why is there an advantage in taking um, in taking fat over carbohydrate when you are in Antarctica and you have to carry food in a hand sleigh? What is the advantage? Very simple, common sense. Common sense, common sense. Answers, guys. Right. Your answer is option 5. Metabolic energy per unit mass is more for lipid. Absolutely correct. Right? Absolutely correct. Sandeep, very good. So let's go to option B. Estradiol, testosterone, and aldosterone. Estradiol, testosterone, and aldosterone share a property which is not shared by insulin and vasopressin. Not shared by insulin and vasopressin. What is that property that is shared by them? Again, let's choose an option. So estradiol, testosterone, and other hormone, other steroid hormone like aldosterone. So all of these, they share one common property, and that common property is the fact that they are. Look at these options. Look at these options. Very very simple. Very simple. They're all derived from. They're all lipids. They're all steroids. They're all similar. What is the common thing in between them out of these options? Very simple question. This one. It's not even a clinical case scenario. Absolutely true. Derived from cholesterol. That's the correct answer. They're derived from cholesterol. Correct. Option number C. In life-threatening acute inflammation of the pancreas, considerable tissue damage is produced by a chemical which is detected in the bloodstream in large amounts. Which is detected in the bloodstream in large amounts. So you all know acute pancreatitis. It can be very fatal. It can be very damaging because there is a specific enzyme. Because pancreas, they have lots of enzymes, right? So they are released and they can produce a lot of tissue damage. So the correct answer in this case would be lipase. Okay, very very obvious. So that's why I've told you the answer. The correct answer is lipase. Let's go to question number D. Let's go to question number D. In patients who have had a heart attack due to blockage of the blood supply of the myocardium, drugs may be given to lower the blood cholesterol level. So, in this case, what will be your answer? In this case, what will be your answer? Too simple, I'm done for today. Okay. Sandeep Rama thinks that this is simple, right? So, it's obviously coronary artery disease risk factor. Okay. Sandeep, see you when we will do more EMQs, and you can also join my Telegram channel in case you wish to get updated regarding more sessions like this at the rate. The interior of the muscle fibers contains many glycogen granules and lipid. droplets. The interior of the muscle fiber contains many glycogen granules and lipid droplets. So what is the function of lipid droplets here? What is the function of lipid droplets here? What is the function of lipid droplets in various cells? Lipid droplets, what is the function? Very, very simple again. They are going to function as a source of energy. They're going to function as a source of energy, right? So we've done quite a few questions now. Let's go to question number 7. Hopefully it will be slightly more difficult than this. Question number 7. For each of the descriptions A to E, select the most appropriate option from the following list. Right? So you've read these options: neutrophil, polymorphonuclear granulocytes, so neutrophil, platelet, lymphocyte, thrombocytopenia, leukemia. So these are five words, and you have to choose their correct descriptions. Again, might be very, very simple. So which of the following is responsible for ingesting invading bacteria? So right, you can answer this even without the options. Responsible for ingesting bacteria. So again, so the answer given by Ram Prasad Dhakar is 2. The answer that you've given is 2. I think that is for source of energy. Right, that is for source of energy. Ram Prasad, question number 7 में first का answer बताओ. Responsible for ingesting invading bacteria. Very, very simple, not anything difficult. Okay, the correct answer is meanwhile, while you guys tell me the correct answer, there was something that I had discussed yesterday, and this is a very, very important potential MCQ that I want to discuss. I did not discuss this today when we were doing body fluid volumes. Potential MCQ, and this is from a slide that is taught in AIMS Department of Physiology, right? And this is a potential MCQ for your INI-CET, right? And there's a mnemonic also that I have for you guys here. So listen to this very, very carefully, right? Sandeep, you're right. The answer is polymorphonucleoside, right? For this, the correct answer was uh, cell that digests invading bacteria, right? So you're right for that particular answer. Let's talk about this question, right? So there are some substances that you use that are called as indicators, which are used for measurement of body fluid volume. So what do you do basically if you want to get an idea of how you are exactly going to do it? If I tell you how you are exactly going to do it, the way to go about it is that you have a body fluid compartment, right? There is some fluid in that compartment. So what you do is you add a substance X, let's say you add it in 5 grams, right? And then you measure the concentration. Then you take this out and you measure the concentration of the substance. So if you get the concentration, you do concentration is equal to 5 gram divided by volume, and then you find the volume by dividing the mass by the concentration, right? So essentially that is what you do. And the important thing for that is that this X should easily dissolve here completely. It should dissolve and it should not escape from this membrane. It should not escape from this fluid compartment, right? It should not redistribute. Okay. So for specific body volumes, you have specific indicators, right? This could be an MCQ. This could come in a statement based form, right? However it comes, it could come as match the following. Okay. So the first thing that I will tell you will be the most important. The first thing that I'll tell you will be the most important. Okay. First most important one is plasma volume. There's also been a previous AIMS MCQ from this question. Plasma volume. So which substance is used for the measurement of plasma volume? There are two substances. Radioactive albumin. Radioactive albumin. It can be used, or you can use Evans blue dye, that is T1824. Evans blue dye. Okay. So what do you do? How do you remember this is something that I can tell you. Okay. So Evans, so it is used for measurement of plasma volume. Plasma volume, right? So the word plasma, if you look at it, at the end it has asthma. Asthma, right? So asthma means asthma. It means sky. Sky. And what is the color of sky? Neela asma, right? Neela asma, or blue sky. So the color is blue. And what is the color of the dye? What is the name of the dye? Evans T1824, right? And you can also use albumin. So that's the first mnemonic that I have for you guys. This is very, very bad mnemonic in the sense that it is slightly absurd, but that's how you will remember things. Okay. Second mnemonic is for extracellular fluid. Measurement of extracellular fluid. It has to be done very strategically. And what is a strategy called in Hindi? Niti. Niti, right? You might have heard of Niti Ayog, right? So Niti is sodium, iothalamate, thiosulfate, and inulin. These are the four substances. NITI, right? That is used here. Then measurement of total body water, you can either use radioactive water, you can use heavy water, or you can use antipyrine. Okay. Then very, very important is that intracellular fluid and interstitial fluid, these cannot be calculated. These cannot be measured directly. They have to be calculated. So intracellular fluid, you will subtract extracellular fluid from total body water. And to calculate blood volume, you will use chromium labeled, radioactive chromium labeled RBCs, right? And then to calculate interstitial fluid, you will subtract the plasma volume from the extracellular fluid volume, right? So this table you should have on your fingertips. There are two mnemonics and one that you have to remember, and the other are calculations. Chromium is relatively easy to remember, right? So you guys will be able to attempt an MCQ from this. Did you guys like the presentation? Relatively, this whole thing, it should be clear in your mind what all we have done, what is the mnemonic. Very, very important to memorize it in this way, the way I'm telling you, right? So the answer for this was polymorpho nuclear lymphocyte, right? That is PMNL, that is also called as neutrophil. The blood cells most affected by AIDS, most affected by AIDS, which are the blood cells which are most affected by AIDS? Tell me the exact ones. right? So T helper, CD4 positive T helper lymphocyte. Okay, so you will be able to find from the options. A condition where abnormal white cells invade the bone marrow. Right, Vishnu Das, you're absolutely correct. Yes, you guys are absolutely correct, no doubt about it. Myeloid leukemia, right? Very, very specific. So the answer I was looking for here is leukemia. You cannot say it is myeloid or lymphoid. Okay. So for that you need to know about the markers. Right? So it can leukemia. It can either be lymphoid or it can be of the myeloid series. So how did you say, Dr. Prasad, that it is a myeloid leukemia and not a lymphoid leukemia? Do you have do you know how to differentiate between a lymphoid leukemia versus a myeloid leukemia? What do you think is the difference pathologically? So the way to differentiate would be through the granules. Generally, it will be you can differentiate based on whether you see granules or not, because the myeloid series will have granules, and the lymphoid series will generally lack granules. Um, but I'm not going to the exact pathology here. So very important to understand one thing at this stage, and if you understand it earlier, it's better. I want you to be very clear with these words. So blood cancer, no, no, no. That's a wrong concept. Blood cancers, they are of two types. They're of two types. Hematological malignancies, as you call them. They can be of two types. Okay. There is something called as leukemia, and there is something called as lymphoma. There is something called as lymphoma. So what you are talking about is called as lymphoma. Okay. So both of these are malignancies of the blood, right, or the blood cells, and there are two types. Okay, it can either be a leukemia, it can either be a lymphoma. Now, what is the difference between a leukemia or a lymphoma? Leukemia is going to involve your, generally it will involve your bone marrow. It will generally involve your bone marrow, or it can involve your blood. Lymphoma generally involves your lymph nodes. It involves your lymph nodes, right? Now, leukemia, it can further be classified based on the kinds of cells. It can be myeloid or it can be lymphoid, depending on what is the progenitor that is leading to this proliferation, right? And again, further here, you can have acute myeloid leukemia, chronic myeloid leukemia, acute lymphoid leukemia or lymphoblastic leukemia, right? And chronic lymphoblastic leukemia. All of these are the possibilities. Clear? Have I made myself clear? Now understood about leukemias. Any doubts about leukemias? Hmm? Yes, tell me your doubts. What is the doubt that you have, Dr. Prasad? Lymphoma, do you know the types of lymphoma? Two types of lymphoma you should know that I'm telling you. Hodgkin's lymphoma and non-Hodgkin's lymphoma. Okay, this may be then there are further subtypes, but for now that is going to be enough for you. Clear? Doubts, doubts, doubts. Chalo. The smallest cellular element in the blood. The smallest cellular element in the blood. The smallest cellular element in the blood. Baki leukemia, lymphoma, when you come to second prof, it's there in detail. Right. Correct answer is obviously platelets, smallest cellular elements. Remember, there used to be a question in your Allen modules or your PMT modules. The question used to be what is the smallest cell in the blood? And in that case, they did not consider platelets to be a cell and they said the answer is RBC. The reason for that is that platelet it is often considered as fragments of cell because it is due to fragmentation of megakaryocyte, right? So that is one reason that cellular element is specified. Again, same answer, it's going to be platelets. Okay. So now since you guys mentioned, I am going to tell you one point that is very, very important. That is actually a pathology point, to be very honest. But since you guys mentioned, I'm going to tell you how to approach pathologically, how do you differentiate between leukemias, and it's also relevant to your immunology, right? So if you have acute leukemia, if you have acute leukemia, okay, so you will have to differentiate between lymphoid and myeloid, right? If you have acute leukemia, you will have to differentiate between lymphoid and myeloid. So what will you do? You will do something called as a bone marrow biopsy or a bone marrow aspiration, right? Bone marrow biopsy karoge, and how will you diagnose it? The blast cells must be greater than 20%, right? That's the diagnostic criteria. That's the diagnostic criteria, right? Now, once you have seen that the blast cells they are more in number and you are satisfied with your understanding that it is definitely a leukemia, it's definitely a leukemia, then you will want to categorize it into acute lymphoblastic leukemia or acute myeloid leukemia. So for looking for lymphoid precursor, what is the approach? And for myeloid precursor, what is the approach? Okay, wait, let's write a lymphoid on this side and myeloid on this side. Okay, so microscopically, how do you differentiate between these two kinds of cells? So the differentiating features for myeloid cells, you will look for a granular cytoplasm. I told you they will be granular, right? They will have a granular cytoplasm along with prominent nucleoli. They will have prominent nucleoli. Whereas in case of a lymphoblastic leukemia, the lymphoblast cells, they will have a granular cytoplasm with nucleoli absent. Nucleoli absent. So that's the differentiating feature. Now, if you want to differentiate based on staining characteristics, please remember this is cytochemically, this is pass positive with block like staining, right? Block or dot like. Whereas in case of AML, the stain can be myeloperoxidase, right? You can again stain with Sudan black. You can stain with pass positive. They're also going to be pass positive because of the presence of erythroblasts. But this will be a diffuse staining. This will be a diffuse staining. This was dot or block like. Dot or block like. And the fourth possible marker is AML markers, AML M3, M4, M5. Okay, so no need to go into so much detail. My main point was to tell you about these histological features which might be useful to you. Okay, chalo. Let's go to question number 8. Let's go to question number 8. For each of the descriptions related to body fluids A to E, select the most appropriate option from the following list. So your options include osmolality, plasma albumin, glucose, sodium, plasma globulin, right? So you have five options: osmolality, plasma albumin, glucose, sodium, plasma globulin. So first option, responsible for most of the colloid osmotic pressure of the plasma. Not glucose. Hey Rabba, how can you be so wrong? Very, very wrong. Very basic concept taught in AIPMT only. I thought this would be very simple. Most of the colloidal osmotic pressure of the plasma. Have a look at the options again. I guess you've forgotten the options. Plasma albumin, glucose, sodium, plasma globulin. Okay, obviously the answer will not be osmolality. But out of these four options, what is your answer? Not sodium. Come on. Okay, I'll frame it in different way. Which of the following has maximum contribution to BCOP? Now remember maximum contribution to BCOP. Okay, in liver cirrhosis, I'll frame it in a different way. In liver cirrhosis, why is there edema? Why is there edema? Hepatic cirrhosis, or why is there edema in hepatic cirrhosis or liver cirrhosis? Yes, the correct answer is option 2, plasma albumin. How can you forget this? Maximum contribution to blood colloidal osmotic pressure. It's a very specific term. It's not asking you maximum contribution to osmolality. It is not asking you maximum contribution to anything else. It is asking you maximum contribution to osmotic pressure, colloidal osmotic pressure, that is VCOP, and that is contributed by plasma albumin. Okay, this is taught when you are doing plasma proteins. क्या एल्ब्यूमिन का मेन फंक्शन ही ये होता है. डोंट मेक दिस मिस्टेक, कम ऑन. Very basic mistake for you guys to make. Responsible for fluid shifts between intracellular and extracellular fluid. So, which of the following is responsible for fluid shifts between intracellular and extracellular fluid? Which of the following is responsible for these fluid shifts? Now tell the main culprit. That is because of what is the cause of these fluid shifts? Main culprit here. Right. Correct answer is sodium now, because sodium is responsible for plasma osmolarity. Sodium is the main contributing factor to plasma osmolarity. So now your correct answer for this question will be osmolality. Your correct answer will be osmolality. So the main contributing factor for that is sodium. Provides about half of the osmotically active particles in the ECF. Provides about half of the osmotically active particles in the ECF. Okay, right. Sorry. Here the answer was not sodium. Here the answer was osmolality. The osmolality is responsible for the shift, and in this case, osmolality is mainly contributed by sodium, right? So here the answer will be sodium, and here the answer would have been osmolality. In the previous case, the answer would have been osmolality. Garvit, you were right. Garvit, I'm sorry, you have to delete your answer. The correct answer for this case, for option B, will be osmolality. I forgot that it was also in the options. Osmolality is going to be the correct answer in this case, right? And for the third case, over half of the osmotically active particles are contributed by sodium. Okay, sorry, Garbit, you were right. Sandeep, I had given the wrong answer. Even not wrong answer, but the more appropriate option in the previous one was osmolality. Here, the more appropriate option is obviously sodium. Right? Let's move to option number D. Mainly responsible for opposing the leak of fluid out of capillaries, right? Again, it is plasma albumin because it contributes to BCOP. Again, the same answer, plasma albumin. The same answer, that is going to be plasma albumin. That is going to be your correct answer. Plasma albumin. Correct answer. Right. Next question, last question for this particular one. Determines the freezing point of a solution. Determines the freezing point of a solution. So you have read this in class 12th. There was a chapter called as colloids, right? There was something about colloids. Colligative properties. You remember colligative properties? Remember there was a calculation freezing depression in freezing point. Depression in freezing point colligative property which was calculated using a formula. Depression of freezing point called as cryoscopy. Cryoscopy. Remember, measurement of this difference was called as cryoscopy. So this was again the formula there. It had a factor for osmolality or molality, right? It was dependent on molality. So here your answer will be osmolality. Remember the chapter colligative properties in chemistry. Okay, ninth question. Very, very important. There are some intravenous fluids that are given to you. You have to choose which infusion has to be given when. 50% glucose, 1.8% saline, 5% glucose, 0.9% saline, 8.4% sodium bicarbonate. And this will help you to understand which fluid is to be given when. You will understand the function of each kind of a fluid and you will understand which fluid is to be given when. So which of the following is an isotonic solution which expands mainly the extracellular fluid volume? What is your answer? An isotonic solution which expands mainly the ECF volume, which expands mainly the extracellular fluid volume. So when will you give this? Obviously, when you only want to increase when the ESF volume is low. So when you want to increase the ESF, you will give this. And you have to maintain the tonicity, that is isotonic. You have to give as isotonic. So the two solutions that are actually isotonic are 5% dextrose or 5% glucose and 0.9% 0.9% NaCl, right? So these are the two. This is also called as normal saline, NS. So what is your answer? So as you all know, the dextrose, it will go to the ICF also, because glucose, it enters the cells also. And you know, glucose, if it is in blood, it will also enter the cell. You know that insulin helps in taking up glucose. But NaCl is not a cation of intracellular fluid. It is mainly present in extracellular fluid. So it will not enter the ICF. It will keep the chloride and water with itself only. So NaCl, or 0.9% NaCl, that is normal saline, it is an isotonic solution which will mainly expand the extracellular fluid volume. Is this understood? This was understood? Okay. Okay, right. Let's go to question number 2. An isotonic solution which expands both intracellular and extracellular volume. Answer. What is your answer, guys? I've just told you. I've just explained the entire concept to you. I just told you that 5% glucose will do that, because 5% glucose is one that will also be there in ECF and ICF, unlike sodium, which will not go to the ICF because it is a cation of the ECF. In the ICF you will have mainly potassium, so it will only remain in the ECF. So that is the difference. Both of these are isotonic, but what is the main difference? Sodium will be to correct the ECF dysfunction. This will correct both ICF and ECF. So this will be when there is a decrease in total body water. There's a decrease in total body water, right? Option C. A major nutrient used in intravenous nutrition. Used in intravenous nutrition. A major nutrient. So now just have a look at the options. Which of these looks like a nutrient to you? again. So your answer should be, so intravenous nutrition, it should give you a hint that again we are going to talk about glucose, and when you have to use it as a nutrient, you don't use isotonic. In that case you can use 50% glucose. All right, 50% glucose, although generally only 5% dextrose is used. But in case you have to use it as an energy source, you can use 50% of glucose. That will have around 500 gram glucose. That will give you around 2000 kilocalories that is required for the daily requirement of an adult, right? Now look at this one. Look at this one. Very, very easy. Hypertonic fluid with about twice the osmolality of plasma. Come on, guys. This is itself a very, very big hint for you. So, which is isotonic with the osmolality of plasma? Isotonic with the osmolality of plasma is 0.9% saline, right? That is normal saline. So, if you want twice the osmolality, what will you give? 1.8% saline, right? Nothing difficult in this. Nothing too difficult here, right? A fluid occasionally used to treat severe acidosis. So, what will you use to treat severe acidosis? Only one option remains. Very, very simple for you guys to answer. You can use 8.4% sodium bicarbonate, right? And while you're using this, because of the severe acidosis, you will need some minor weak alkali to neutralize it. So, you will use bicarbonate. In that case, you will use sodium bicarbonate, right? But it has to be titrated well, otherwise, it can lead to alkalosis. Okay. Um, although it's very, very correct, you cannot simply correct acidosis by just giving sodium bicarbonate. It's a more complex thing than that, right? You cannot simply say that अच्छा acidosis है तो इतना sodium bicarbonate दे दो ठीक हो जाएगा, because that is just a way to buffer. You have to actually go to the cause, right? So last question related to all of these concepts. Very, very simple. For each of the body fluid disturbance A to E, select the most appropriate option from the following list of abnormalities: hyperosmolality, hyposmolality, hyponatremia, hyperkalemia, raised hematocrit. excessive retention of water by kidneys. What will happen in this case? If there is an excessive retention of water by kidneys, as can occur due to an excess of ADH, right? So you all know about a syndrome called as syndrome of inappropriate antidiuretic hormone, SIADH, right? Hyposmolarity, absolutely true. Excessive retention, so that will lead to hypoosmolarity. Absolutely correct. Hyposmolarity, right? Excessive loss of plasma and extracellular fluid as a result of severe burns. What is your answer for this one? So in this case, what are you likely to have? It's kind of an opposite situation, right? It's an opposite situation. So what will you have? We have discussed this case before. Excessive loss of plasma. So if from blood has two components, plasma and RBC, WBC, etc. Right? So if you remove plasma, what will happen? What will happen? There will be a what will happen? We've talked about a case where the hematocrit. Do you remember that the hematocrit of the patient was 54? Hematocrit of the patient was risen to 54. So elevated hematocrit. The correct answer will be elevated hematocrit. Right, Garvit? Absolutely correct. So Garvit, are you finding these questions interesting? I hope you are, because they're about to end right now. And after that, I have a short discussion of the most important points from general physiology to sum up this class. Also be done as a separate class so that there is more emphasis on them. So likely to be present, which condition is likely to be present if the blood glucose level is 30? The normal is 5 to 8 millimole per liter. Likely to be present if the blood glucose level is 30. Normal is 5 to 8 millimole per liter. Blood glucose level is highly elevated. So which of the following is likely to be present? So you know glucose is mannitol. All of these substances, they can cause something that is called as, what can they do? They can cause hyperosmolarity. They can cause hyperosmolarity, right? So that is the concerning point here. They can cause hyperosmolarity. Produced by drinking excessive amount of water. Produced by drinking excessive amount of water. So excessive amount of water you can drink, that is polydipsia. Or if you are having a psychiatric condition, neurogenic psychiatric condition where you are drinking too much water, right? So what will happen if you drink excessive amount of water? What is the disturbance that will be produced? Right. So obviously it will be hyponatremia. It is called as dilutional hyponatremia, right? So this will cause dilutional hyponatremia. Dilutional hyponatremia, right? Okay. So which of the following is likely to cause swelling of the brain cells? Likely to cause swelling of the brain cells. Um, Again, it can be hyposmolality. It can be hyposmolality. That will also disturb brain function. Not hyper, hyposmolality. Hypoosmolality, right? So for this case, it could also have been hypoosmolality again, but I would prefer to go with dilutional hyponatremia, right? So now after this, there are some important points, and I will be uploading these as shorts on not as shorts, maybe as 5 minutes videos on the Unacademy website itself, on the YouTube platform itself, and you can watch out for these, and these will really clear your concepts very quickly. So I don't want to make this session too long, because I am sure you guys are also very tired. You don't have the energy to listen as much. So I'll put these as short 5 minute sessions, so that you guys can quickly summarize or recap whatever concepts you want to. And so I'll tell you about intercellular junctions and their clinical correlation. I'll tell you about homeostasis feedback circuit. I've already told you about this, and the mnemonic. We'll also talk about the unconventional role of macrophage, the role of mitochondria in immunity, role of lysosome in as a metabolic switch, fourth component of cellular cytoskeleton called as septin. Okay, this is one single point that you can keep in mind. There's a fourth component of cellular cytoskeleton. So far, you've studied actin, microtubule, and intermediate filament. There's also a fourth component, and that is called as septin, right? So that is what you need to know from here, guys. So I'll be ending the class right now. So thank you so much for watching. Do remember to hit the like button for this particular video and subscribe to the channel Let's Crack NEET PG. And do also join our Telegram channels. The Telegram channel link is also in the description. Okay. And Chetanya 10 or SPCM is the referral code that you can use to get a 10% discount. Thank you so much for watching. Do remember to hit the bell icon for notifications. Do drop a comment if you liked the video, right? Bye bye, guys. Take care.